Data doesn't lie, your go-to for the science behind the art of parenting.
Hi folks, welcome to this week's video. This week we're talking about the second screening test, heart test, that we do in the baby. Again, a screening test is inexpensive, easy to do. We want to be able to detect disease before it gets to its critical point and be able to intervene in this disease so we make a difference in the baby's life. So stick with me and let's dig in on what the heart screening test in the baby looks like. So just a bit of background on heart defects and why we screen for them. About 3% of babies are born with a congenital defect, just a defect of any part of the body that wasn't formed, and 2% of those would be heart defects, meaning the heart is the one that is the part of the body that wasn't formed well. And congenital heart defects are actually the leading cause of illness and death that is related to a defect at the time of birth. So it's important that we look at it. Now, if you took 10,000 babies, 18 of them would have critical congenital heart disease. And those are the specific ones we're really trying to identify. We use critical congenital heart disease because if we do not intervene with surgery or intravenous catheter-based procedure in the neonatal period, those babies would not survive. That's why we call it critical congenital heart disease. So those are just the statistics and the numbers. You could argue that, well, we get prenatal ultrasounds. Why don't we see those? Why don't we pick them up in prenatal ultrasounds? We do pick them up. We do pick some up, but we pick less than 50% of them up on regular prenatal ultrasounds. So, and this is not because of how well the ultrasound was done. Could be, but mostly it's not. It's really based on the physiology and how blood is flowing when the baby's in you versus how blood is flowing when the baby is outside and is an independent being. So knowing this, as the baby's physiology shifts and blood flows, there's a particular duct or bypass that is open in the baby called the patent ductus arteriosus, and this allows blood to sort of bypass the lungs in utero when the baby's in you. And when you come out, that duct or that shunt starts to close, and it's normal, it should. And it typically closes in the first week, 2 weeks of life, and it should do that. The problem is if you have a heart that wasn't formed the way it should have been formed, that now depends on that duct to get blood to where it needs to go, either to the lungs or to the whole system, and that duct closes, it becomes critical for the baby because blood is not going to where it needs to. So we don't want this to happen at home. We want to be able to, even with the duct open, we can detect low oxygen numbers in the blood when the baby's in the hospital, hence the screen, and then intervene. So that's sort of the basis why we want to do it early, prior to discharge. And even again, if the baby's born at home, this should be something that's done within the first few days of life. We want to especially do it after 24 hours of life because we know that most of the physiology has started to shift by then. Okay, so that's sort of the reasoning behind it. Now, what do? It's called the pulse oximetry test. It's a probe, a sensor that's put on the right hand. One is put on the right hand and the other is put on any of the lower limbs of any of the feet. And we are looking for how much the hemoglobin in your blood is saturated, what percentage of the hemoglobin in your blood is saturated with oxygen. We want to, and there's a criteria for it, but at its most simple, you should have numbers that are normal, meaning greater than 95, and there should be no difference or little to no difference between the two numbers, the right hand and the lower limb. That difference should be less than 3%. So that's really what we're looking for. If you don't pass the test the first time, we can repeat it. But at that point, if you're failing again, the baby's likely to get an ultrasound of the heart to then tell us exactly what the structure of the heart looks like. So that's the basis behind what the heart screening test looks like and why we're doing it. And even as a screening test, we can and we do still miss some congenital heart diseases, but it will pick up most of them. So the work is not done, of course, right? So as the baby goes home, the pediatrician follows up, how well are you growing and all that stuff. But at least our goal is to catch the critical ones in the newborn period where we can intervene. If you have any questions, let me know in the question bar below. If not, share, like, and subscribe, and I'll see you guys next week for the completion of this series. Have a good week.